This episode was recorded in Q4 2025. The information provided in this podcast is for educational and informational purposes only. The views and opinions expressed by hosts and their guests are their own and do not necessarily reflect those of the Irish College of GPs. By listening to this podcast, you acknowledge that no party is liable for any direct or indirect consequences resulting from the use of the information provided. More information can be found in the show notes or at irishcollegeofgps.ie.
1.5 million people are seen every year in A&E, but interestingly, in out-of-hours GP co-ops up and down the country, some 2 to 3 million consultations take place every year.
Hello and a very warm welcome to the GP podcast from the Irish College of GPs with me, Dr. John Maher. Today, I'll be joined by Dr. David McConaghy to discuss an approach to working in the out-of-hours setting. Here's David.
My name is David McConaghy. I am the Irish College of GP's clinical lead for prevention. I'm part of the integrated care team for chronic disease at the HSE. I'm a GP in Sallins, County Kildare, and also medical director of TLC-Doc, an out-of-hours GP co-op in Dublin.
During our discussion today, David shares numerous clinical pearls of potential use to GP registrars, newly qualified GPs, recent arrivals to Ireland, as well as seasoned vets, for want of a better phrase, in general practice. And I hope you'll find the episode of value to you. Topics covered by David will include the importance of the out-of-hours service in the broader Irish healthcare context, tips for newcomers to the out-of-hours service and a broad approach to providing healthcare in this setting, tips for managing difficult requests during the consultation, how to appropriately manage requests for things like illness certs and medications of potential misuse, how to manage house calls and palliative care patients. And as usual, we'll provide some useful resources that you can access from your phone or from your doctor's bag in the out-of-hours setting. And you'll find links to these resources mentioned today in the show notes, where you'll also find a complete transcript of the show. David began today by reflecting on his own experience as a doctor in the out-of-hours setting over his career in the last 20 plus years.
Yeah, so at the moment, whilst I'm medical director at TLC-Doc and also part of KDoc, the Kildare Co-op, I've had quite varied out-of-hours experience. Obviously, as a hospital doctor, I did call, which all doctors have done. And then as a medical SHO, I sometimes would cover a group of GPs out of hours. So it would be myself, a doctor's bag, a defibrillator, a Vauxhall Nova, and I would look after a town rota for 24 or 36 hours over the weekend when I was a hospital doctor. I then worked in Australia, where I did some remote general practice, and I would be on call 24/7 for 8 days at a time. And then when I came back to Ireland, then I did occasionally the odd shift in a deputising service as well around Dublin, which was a fantastic learning experience. And now I'm privileged to be part of a co-op as well, which I think out of all the iterations of out-of-hours care that I've been through, I think the co-ops offer the highest quality and safest care for patients, whilst being fantastic value for money to the exchequer and quite fair to GPs as well.
Could you just set the scene here for how the out-of-hours service sits in the framework of provision of primary care in Ireland in terms of numbers and stats, please?
So we know that every year in Ireland, 29 million GP and GP nurse consultations take place in ours. 1.5 million people are seen every year in A&E. But interestingly, in out-of-hours GP co-ops up and down the country, some 2 to 3 million consultations take place every year.
So we're looking at significant numbers that don't make their way to the emergency department out of hours. So it's a really important bulwark, you might say, against overwhelming the emergency department and tertiary care services. Is that fair?
Yes, indeed. And our statistics from TLC-Doc would say that our referral onward rate to secondary care, in this case accident and emergency, is under 10%. And even a number of years ago, we had some very good stats when there was a respiratory and influenza outbreak over a Christmas, New Year period. Our onward referral rate to A&E at this extremely busy time when daytime general practice was closed over a holiday period, largely our referral rate onto A&E was around 6%, which is very impressive considering the volumes of acutely unwell people that were being seen.
So again, a really invaluable service for the community and for our hospital colleagues. In terms of newcomers to the out-of-hours service, whether that's registrars or perhaps people who've practiced medicine abroad and aren't accustomed to the Irish system, and they're seeing it through the eyes of the out-of-hours service in the first instance, I guess it's important to start with that idea that the out-of-hours service is not the daytime service, but in a different building. It's quite a different approach in some ways, isn't it, in terms of how to keep yourself and your patients safe?
That's right. And when I sit down with registrar colleagues, I'm a GP trainer as well, my own registrar, or doctors joining our co-op, I often think that being well prepared is half the battle. So with my registrar, I will talk in advance about out of hours, about the differences. So you're in a different environment, you have different computer software, you generally don't know very much about the patient. You're relying on them to tell you their background, their medicines. And so we always talk about just taking a careful history, slowing the consultation down, and also preparation for the shift, turning up perhaps 10, 15 minutes earlier, making sure that you're fed and watered, you're not tired or emotional. And perhaps if you've had a busy day in practice, make sure that you sit down, have a bite to eat, and compose yourself before you start into the consultation. Things that we tend to work on with registrars is that get them to slow the consultation down, introduce yourself to the patient. I think that's really important. It's highly unlikely that they've met you before. And then ask them important questions, things that we really need to know when a patient sits in front of us in an out-of-hours setting is that, are they allergic to any medicines? Have they any significant past medical history? What current medications, if any, are they taking? And then to ask them then to slowly and clearly explain the main reason that they're there in front of you in the co-op, and their ideas, their concerns, their expectations. So taking time to gather that information carefully before then going on to examine, work out a diagnosis and map out a treatment plan.
I found in my own practice, David, I've never regretted having a smile and a warm welcome for a patient in whatever setting I find myself. It can really work in your favour in terms of getting the patient on side and willing to open up to whatever questions you need to ask them.
Yeah, I think that's important. I think the warm welcome, a smile, introducing yourself. I often in out-of-hours introduce myself as Dr. David McConaghy, and then it gives the patient the opportunity, if they want, they can call you David, Dr. McConaghy, whatever they feel most comfortable with. And again, that's important to put people at ease and set the scene before you go into the nuts and bolts of a consultation.
And you mentioned that it is important to note as well that you are somewhat limited in the out-of-hours setting in terms of your access to the patient details. The threshold, I guess, for who needs referral onwards should be appropriately low, given that it, as I said from the outset, this is not daytime practice, and the landscape is a little different.
Yes, again, as I mentioned earlier, referral rates from Irish GP co-ops into secondary care are low. I suppose we need as well, because of the limited information you have and not knowing the patient as well. I would always talk to colleagues about, if pulmonary embolus, myocardial infarction, unstable angina, enter your diagnosis thoughts, then this patient needs to be seen in secondary care. Fortunately, these are rare enough for the presentations, but I think the potential for missing something is somewhat higher when it's a strange patient in a different environment. And in those kind of situations, if you feel that they're part of the thoughts, that patient is better seen in A&E to get where there's ability of radiology, laboratory, etc., to get to the diagnosis.
And on that point, David, you mentioned turning up a little bit early, on your shift to get yourself oriented. And, whenever I find myself in the out of hours, I like to introduce myself to whatever other doctors and nurses are about the house, as it were. Part of it is that you don't know if an emergency is going to come your way, and having a colleague down the hall can be very, very helpful in terms of an extra pair of hands.
Oh, indeed, again. And I always tell any registrar, to go around, introduce themselves to nurses, drivers, administration staff, and the other doctors on, because as you rightly say, you don't know what's going to come through the door, and it's much easier to ask for help if you've introduced yourself to somebody there as well, and for them also, for you, the colleague up the corridor might have an interest in rash, an unusual presentation, and that might be of use as well to show another colleague as well. And it's nice. It's one of those times where there's a bit of collaborative working as well, and that can be very enjoyable and educational also.
Yeah, it's a really good way of looking at it, isn't it? That, given that you have to do 120 hours per year as a registrar, you can see it as a burden on your free time, but you can also potentially see it as a real opportunity to see some things in the out of hours, because oftentimes numerous people will come through the door. Oftentimes the presentations can be acute, so things like rashes, you might see quite a volume of interesting and relevant spot diagnoses just by being attuned to it and being open to colleagues, showing you some interesting cases as they go.
That's correct. Again, you can, by seeing high volume patients, often with acute illness, you build up skills in pattern recognition. You can quickly hone your skills in what a truly unwell person looks like, which is very useful. Also for doctors in training as well, one of your exit exams is the clinical skills assessment. And I often found as a registrar that when I was in out of hours, I would read up on a consultation model. And then here we have in front of me in the out of hours co-op a brand new patient, a case I've never seen before, fit my consultation model and to that presentation. And it upskilled me then for examinations down the line. And again, I'd encourage registrars, if they're listening to this, to maybe consider that. Go and read about Roger Naper's consultation model and use the 5 strands of that on their next 10 out of hours consultations. And again, it's a bit like riding a bicycle. With the practice, it becomes effortless and intuitive.
And you mentioned, I suppose there's a few different competing interests potentially in the consultation room, because you talk about slowing things down to take your time to make sure you capture the information. You also mentioned the idea that in the out of hours there can be quite a high volume, and the importance of having a consultation concept or structure, if you like, such as Roger Naper. So does your consultation style change somewhat in the out of hours setting, or do you have advice about an approach that can be useful for people new to the service?
Yeah, I think what I always try to do is, one, put the patient at ease. Early on, I explain, unfortunately, I don't have any background on you here, unlike your own GP who has computer software with all your important details on. So firstly, are you allergic to any medicine? What regular medicines do you take, if any? do you have any serious health problems in the past? And then I say, thanks very much for telling me all that. Now take your time and tell me what led to you attending us here today. And then I let the patient talk, and I try my best not to interrupt them, let them tell their story. Most people, if you don't interrupt them, will talk for about 1.5 to 2 minutes. But in that period, you could have gleaned all the information that you need to know about that illness, that reason for presentation. And you might actually find that you don't have to ask very many questions before you proceed on then to examination, working out a diagnosis, developing a plan and handing that plan over. I also, when a patient is departing, I take some time to explain the diagnosis, explain the treatment plan, and put a plan in place for the eventuality if something goes wrong. Again, Roger Neighbour's safety netting, to answer the question, what do we do if things go wrong or things don't go to the plan that we thought would happen? And sometimes I'll write this down on a piece of paper, perhaps just 3 pieces of information, and hand it over them. And then before they depart, I always make sure that either the patient or their carer or parent, have I explained everything well enough to you? Do you understand the plan? Is there anything else you want to ask me or tell me before you go? So that they leave confident of what you've told them and up to speed, and that you also know going that they understood your plan. And again, this will hopefully lead to better healthcare outcomes.
So that sounds, really a reasonable approach, David. And I guess the hazard here is it's all well and good to execute everything really effectively and competently. But if you don't reflect it in your notes, you're leaving the door open to problems down the line potentially. And maybe more so in the out-of-hours service, again, given the hazards that we've already outlined.
John, that's correct. Writing up good notes is very important because, firstly, notes are a legal obligation on practitioners, but they're also important information because you're handing the care of this patient on to their own GP the next day, the next week. And it'd be important if the patient sits down in front of their GP, that their GP has a good idea about what the reason was that they were at the co-op and what the treatment plan was. So that's also unfortunately, if you're going to be complained about, it's statistically speaking more likely out of hours. Mainly, and the reasons for this are multifactorial, but it's the patient is seeing a different doctor with access to limited information in an out-of-hour setting, and they're more likely to be acutely unwell. So that unfortunately is the case. Again, when I'm talking to colleagues about writing up notes out of hours, I like a model called what I call the SOAP-IF model. So S is for subjective, what the patient told you. Objective is what you found on examination. A is for assessment, your working diagnosis. I is for the information that you pass to them. F is for the follow-up. And P is for the plan of action, the medicine you prescribed, the undertakings that you've asked them to do in relation to their illness. And I think if you can remember the SOAP-IF and make it your regular note out of hours, this will, when you're busy, you'll revert to type and do this process. And it means that when a GP is under pressure, they will still write good quality notes that will aid ongoing care, and also if a question was made about the care they delivered, help them defend it. Unfortunately, I have to deal with the odd complaint as a medical director of a co-op, and I'm grateful that my colleagues write good notes, where they outline that examinations took place, what they found, observations were done, and that a plan was handed over and a working diagnosis. And it does make these complaints or questions about care much more easy to defend.
I suppose we're lucky in the sense that there are so many online resources available to patients now, and we can give them a bit of a steer around what are the more reputable sites. And one very important site, again, I guess, for the out-of-hour service for clinicians is antibioticprescribing.ie.
Correct. Because of the nature of out-of-hours, we see more acutely unwell people, and therefore the antibiotic prescribing rates are higher out-of-hours. But this is, I feel, justified, and we have some good international data, some studies from the Netherlands that show that antibiotic prescribing is higher out-of-hours, but justified. And again, I'd urge colleagues, and Irish GPs are very good at this, to prescribe antibiotics appropriately with reference to antibioticprescribing.ie, a fantastic, useful resource where it will help you out in various scenarios, conditions, and also regarding dosage, what to do in particular allergies. So it's a fantastic resource, and thankfully widely available, whether it's on your desktop in the consultation or on your smartphone.
So thanks, David. So that's, reflects the importance of antibiotic prescribing.ie and where we sit in with our international peers in terms of our prescribing patterns. And while we're on that topic, another potentially thorny issue that springs to mind in the out-of-hours setting is patients who are potentially seeking particular medications. I'm thinking about the controlled drugs, opiates, Z drugs, things like pregabalin, sleeping tablets, that kind of thing. Do you have any tips around how somebody can approach such consultations?
Again, I think this is something that each individual out-of-hours co-op needs to have a policy on. And at TLC, we discourage people from prescribing any of those classes of drug that you mentioned. But of course, there may be an occasion where you have to prescribe these drugs. Someone could be have had a grief reaction or be acutely anxious, and it may be entirely appropriate to prescribe a benzodiazepine. I think the advice here would be a short course for enough days to get them until they can see their own GP again. Again, unfortunately, these drugs that you mentioned are often abused, and some individuals do see an out-of-hours co-op as an opportunity to source them. So I think it goes back to the co-op having a policy around these to a limit on what drugs can be prescribed and if they are for what duration, and also similarly around 6 certificate duration as well.
The HSE Medicines Management Programme are just reminding me, they've got a very useful one-page guideline on prescribing benzodiazepines. I think some of the information from that is equally relevant in the out-of-hours service as well, and some of the approaches can be more broadly applied, I think, to controlled drugs. So I might put a link to that in the show notes. And similarly, David, how about people seeking 6 certs?
There's an obligation on us as practitioners and from the Medical Council as well to be reasonable in sickness certification. And again, our policy would be that to limit a sick certificate until they can get back to their own GP to have the certificate extended as well. This sometimes can cause friction, but again, I think we have to, as GPs looking after somebody else's patient out of ours, be judicious and fair. So about what is an adequate amount of time off, but if you had someone looking from you to extend a certificate for example, 2 weeks for a self-limited illness, this wouldn't be appropriate. And I think you just have to politely tell them, this isn't really what we do in this co-op. We've a policy against it, but I will write to your own doctor and you can contact them at the next working day opportunity and discuss that certificate at that stage with them.
And you mentioned both on the medication side and on the 6 cert side, David, the idea of policies. I think even if the particular service or centre that you're operating from doesn't have clearly written policies on the wall, for example. I found it useful when I find myself in such settings to be able to say to a patient, I'm not making a judgment on you. This is not personal. It's simply I am disbarred from providing you with what you are looking for because of the policy of this organization. And it can actually diffuse situations when you're not making it about you personally, choosing not to do something, but to kind of offer it up to a higher power, as it were, in terms of the organization and what you can and can't provide in this setting. So it can be quite a useful tool, can't it, with potentially fraught consultations like those?
Indeed, and again, it's just a bit about being prepared again as a recurrent theme in the out of hours setting. But again, as an organisation, most co-ops have committees, medical directors, and at that level, it's good every now and again to say, well, what's our current thinking on potential drugs of misuse? What's our thinking on sickness certificates as well? What's our thinking on antibiotic prescribing and such? And in many co-ops, I know in the past we've audited antibiotic prescribing in the out-of-hours setting as well. And also feedback from GPs as well. It's important that if you're listening to this, you're a GP in a co-op and your co-op has a particular approach to any of these topics, sickness certification, like that you feed back to the medical director any concerns that you had. And also it's important too, in a large organisation like a co-op, if you witness good care or a patient compliment about care delivered by one of our co-op colleagues, that you share that with the medical director and it's shared on. A significant event analysis doesn't always have to be about a negative thing. Often it can be good to celebrate good care, proper care, good outcome.
Great, because I guess it's easy to fall into that mode where we pass compliments by. We're so busy, and to focus on the negative. So it is good, as you said, to step back and actually enjoy the compliments if and when they come your way. The next thing, David, that springs to mind in the out of hours setting is those out-of-hours services that offer house calls. And what I'm thinking is, obviously, many of the house calls that we're asked to see are appropriate and should be actioned. Sometimes if I see a triage note for a house call, sometimes the symptoms may not seem so severe to necessarily, let's say, warrant a house call in every case. And I'm always mindful of the fact that, especially if I'm on my own or I'm overnight in a centre, getting into a car and going on a house call could cost me, an hour or more out of the centre. And then when you come back, you could be faced with, a barrage of patients waiting to be seen. So in terms of dealing with that caseload of house calls, have you any strategies or tips to share with people starting out?
Yes, house calls in Irish general practice as a whole are becoming less frequent, and I've had over 20 years now of working in Irish co-ops. I would think that the number of house calls is actually on the decrease, but there are times when a house call has to happen. For example, palliative care being an example, and is really important in this case. Often from co-op to co-op, it varies. The house call decision to may have been triaged by another colleague, a nursing colleague, another GP colleague. And I think if my advice would be that if you looked at the call sheet and you felt some uncertainty about whether this house call is needed, I don't think there's any issue with phoning up the patient, the carer, and just re-establishing the facts and see is that house call absolutely necessary. We all know, and I don't think there'll be any disagreement on this, the safest place to see a patient is in an office setting where you have some support around you, you have proper lighting, all the equipment you need. It's hard to deliver high quality care from the boot of a car. Although our co-ops do have lots of well-stocked bags, vehicles, etc. But where possible, it's better to get someone in face-to-face. But again, I would certainly feel that if I thought that the call could be managed remotely or over the phone, perhaps, if that was appropriate, or to try and have a chat with the patient, their carer, to see could they be brought in, or if it can be safely maybe postponed till the morning to daylight as well. They're all appropriate things. Again, it's hard to give definitive guidance here, and I think sometimes you just have to phone up, take your time and work out the situation, ask the questions that need to be, and sort of make your decision from there.
And you mentioned the palliative care patients, and what came to mind, David, was a very useful guide that was published during the COVID pandemic. You may recall, I think it was a one-page A4 sheet with some of the common presenting palliative symptoms and management strategies that didn't necessarily involve a syringe driver, like, using the transdermal route, the PR route, that kind of thing. And I kept that in my doctor's bag, and it was a really useful one, to refer to. So I might try and dig that out and put a link to that in the show notes too. I think all these little resources, whether it's a copy of the Oxford Handbook on medical emergencies, or even the emergency section in the back of the handbook, that palliative care guide, the antibiotic prescribing website, etc., these small little time savers that you can have at your fingertips can really save you a lot of stress on the day or on the night. Isn't that it?
That's right. Again, having useful and easily accessible resources, the BNF, the MIMS, as well, the other resources you mentioned to hand now. And we're blessed. Everyone has a smartphone in their pocket. There's usually internet connection, and so we can look up things easily, again, to the in the best interest of getting a good outcome.
And one other resource that I've come across, David, is a newer app called OLAS Medical, EOLAS, which has things like the BNF, medical calculators, nice guidelines, all there at your fingertips. So that might be one that's worth looking up as well. And again, I'll put a link to the app in the show notes. Finally, David, some mornings I might go into the out of hours, let's say on a bank holiday, Saturday or Sunday morning, and I pass a colleague who's just on the night shift, and you can tell they've had a rough night before you speak to them, because they're wearing it on their face. So overnight in the out of hours can be a challenging shift, can't it? Because, again, you're expecting the unexpected, and the shifts can be a bit longer, in terms of maybe a 10-hour overnight shift, for example. Any particular advice on preparing for an overnight?
Again, when you're doing an overnight, I think the thing is being prepared in advance. So try and come to the shift as rested as possible. It's not an idea to be coming from another workplace to go straight into a red eye or an overnight shift. Try and be fed and watered, bring food with you, snacks. Pace yourself overnight and try and factor in breaks into your shift, where every few hours you might sit down, have a drink, a snack, so that you are at the top of your game and alert. I think as well, pace yourself, and the temptation might be that there's a large group of people waiting and you're going to go through them quickly. But right, again, it's this advice to maybe slow down, take your time. If you're unsure about something, ask the question again, give the patient full attention, and as well, because you want the best outcomes if at all possible. I think after the shift, then obviously have time off the next day. It's not a good idea to go straight from an overnight into a daytime shift. And I think my advice would be that you at least get home for a few hours sleep before resuming duty again. Again, we're always very grateful to our colleagues that do the red eyes and out of hours shifts and to provide cover for us. But again, co-ops are good. They spread this work out in my experience, and that whilst there are some doctors that prefer to do red eyes and out of hours, the co-op rota managers should be able to manage this and make sure that they get sort of a appropriate time off and they're not overloaded with this overnight work.
Okay. Anything else, David, that you wanted to mention before we wrap up today?
Well, again, I suppose as part of our GP contract is the provision of out of hours services, and I can't see that change any time in the future. We're fortunate in Ireland that there's an interest in out of hours care, both from the HSE that help fund it and from our colleagues who organise it, staff it, and make sure that there are people on duty to see unwell patients out of hours. So we certainly should be grateful in that as a GP in practice. I'm grateful for the co-ops and the cover that they give, which allows all of us to get some downtime, family time, as well, to focus on delivering good care to our patients. Our colleagues who we meet who didn't have access to co-ops, so they practice perhaps, so many practice 24/7. And others were part of town rotas where they'd be on call every fourth night, every fourth weekend, for example. They certainly had challenging times, whereas the co-ops are, albeit it's high intensity, less frequency work, but still very important in the whole scheme of things for the health service.
Okay, I think that's very well put, David, and I think it's a good point to wrap up today as well. So thanks for your time and for your expertise in all things, all matters out of hours, and hopefully our listeners will derive a lot of value from the many pearls that you share today. So thanks a million, David. Many thanks to Dr. David McConaghy for speaking to me today, and don't forget to check the show notes for chapter markers, links to resources, as well as a complete transcript of today's episode. If you have any comments or feedback on today's show, or indeed any suggestions for future episodes, please let us know. You can drop us a line at podcast@icgp.ie. And that's it for today. Many thanks again for listening, and until next time, take care.